Hi guys, today I'm gonna teach you the parasitic disease malaria. Let us begin with the definition. Malaria is a systemic parasitic disease that is endemic to most of the tropical and subtropical world. Malaria represents the most devastating disease in terms of human suffering and economics. It affects the largest number of people in the world with more than 2 million deaths worldwide. This is a febrile illness caused by the hemoprotozoa of the genus Plasmodium. You can see there are several species of the parasite. Anyway, the four main species of the Plasmodium which causes human malaria are Plasmodium vivax, Plasmodium falciparum, Plasmodium ovale, and Plasmodium malaria. So they can produce benign tertian, malignant tertian, ovale tertian, and quartan malaria respectively. So, malaria is generally characterized by the periodic fever, splenomegaly, hemolytic anemia, and a recurrent and chronic cause. Now, let us see the epidemiology, how the disease is distributed throughout the world. So, the species Plasmodium vivax is more prevalent in India, Pakistan, Bangladesh, Sri Lanka, and Central America, whereas Plasmodium falciparum is predominant in Africa, Haiti, Dominican Republic, the Amazon regions of South America, and New Guinea. Both the species Plasmodium falciparum and Plasmodium vivax are prevalent in all of the Southeast Asia, South America, Middle East, North Africa, Ethiopia, Somalia, and Sudan. Why? Most of the infections with Plasmodium ovale occur in Africa, and the distribution of Plasmodium malaria is considered worldwide. In the United States, most cases of the malaria are reported in immigrants from endemic areas and in American travelers. Blood transfusion also has been cited as a cause of malaria infection. Now let us see the etiology of malaria. As mentioned earlier, malaria is a parasitic or protozoal infection caused by Plasmodium species. How this causative organism transmits into our body or our system? The culprit is none other than the female Anopheles mosquito. That is, malaria is transmitted by the bite of an infected Anopheles mosquitoes. Okay, so these Anopheles mosquitoes can introduce sporozoites of the Plasmodium species such as Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, and Plasmodium ovale into the bloodstream. Now let us see the pathophysiology of malaria. To comprehend the idea of pathophysiology, first you should know regarding the life cycle of the parasite. The malarial parasites undergoes a sexual phase as well as an asexual phase. So the sexual cycle takes place in the mosquito, whereas the asexual cycle takes place in human beings. So the mosquitoes which are infected with the sporozoites or the parasites, they inject the sporozoites into host, that is human. So there are several steps in the life cycle as you can see in this figure. The first one is the sporozoites injected by bite and enter the liver. So the sporozoites injected into the vertebrate host reach the liver, that is, they invade the parenchymal hepatocytes within minutes and initiate the proliferative phase, which is known as the pre-erythrocytic stage. So, as the sporozoites multiplies in the hepatocytes, they becomes the hepatic vegetative forms or schizons. So the hepatic vegetative forms of these sporozoites are known as the schizons. So the second step is the schizons in the liver cells. So there is a substep as the schizons in the liver cells, that is, the formation of the hypnozoids of the Plasmodium vivax and Plasmodium ovale lie dormant. So this is known as the exoerythrocytic stage, that is, the Plasmodium falciparum and Plasmodium malaria remain in the primary exoerythrocytic stage in the liver for about 4 weeks before invading erythrocytes, whereas for Plasmodium vivax and Plasmodium ovale can exist in the liver in the latent exoerythrocytic form for extended periods, and therefore infected subjects can experience relapse. So this occurs in case of Plasmodium vivax and Plasmodium ovale. So as a result, in case of reactivation or in case of directly the parasites of Plasmodium falciparum and Plasmodium vivae, the third step takes place, that is, schizons divides to form merozoites. So the schizons divide to form merozoites. Schizons rupture to release daughter cells. They are known as the merozoites that then infect the erythrocytes. And the fourth step is the merozoites release. So you can see the daughter cells of the schizons, merozoites are released from the liver, and what happens? These merozoites released from the infected hepatocytes subsequently infect the erythrocytes following amplification of the parasites in the bloodstream for a period of time and the development of synchrony in their appearance. Clinical attack of malaria occurs. So, as a result of the release of merozoites and their attack to the erythrocytes can result in the clinical attack of malaria. And you can see the fifth step, that is, the merozoites enters the erythrocyte and forms schizons. And the sixth step is the schizons then forms motile trophocytes and starts to divide. So trophocytes are the growing forms of the parasites. So seventh step is the merozoites are finally formed. So when the merozoites enters the erythrocyte and forms schizons, then they forms the motile trophocyte which starts to divide, and finally our merozoites are formed. So these merozoites can invade other erythrocytes or can develop into gametocytes. Okay, so the release of the merozoites causes fever again. So this cycle is known as the erythrocytic stage. So the erythrocytic cycle takes approximately 48 hours for Plasmodium falciparum and Plasmodium ovale and Plasmodium vivax infection. In case of the Plasmodium malaria infection, there is 72 hours for this erythrocytic cycle. So the tertian periodicity, that is the time for the development of fever, is 48 hours for Plasmodium falciparum, Plasmodium ovale and Plasmodium vivax, whereas it is 72 hours, that is the quartan periodicity for Plasmodium malaria is 72 hours. So some merozoites forms gametocytes. So this is our ninth step. Some merozoites forms gametocytes. So these erythrocytic forms never reinvert the liver without developing into sporocytes in the vector, and therefore the malaria infections from transfusion never result in the exoerythrocytic or liver form. So this Gametocytes can be taken up by the insect bite. Then a sexual cycle takes place in the mosquito and the cycle continues. In this figure, you can also see the sites where the drugs act, that we will discuss later in the treatment section. Now you must have understood the pathophysiology life cycle of the parasite. So, as this life cycle completes, the patient may come across several signs and symptoms, and this can lead to the worsening of the condition of the patient. So here is the gametocytes of Plasmodium falciparum species. So it's just for your information. Now let us look into the clinical presentation of malaria that a person come across. So the initial presentation of the infection can be non-specific fever, chills, rigors, diaphoresis, that is sweating, abnormally sweating. So this can be a result of infection or the side effect of a drug. So here in this, it can be the cause of infection, malaise, vomiting. Also you can see orthostatic hypertension and electrolyte abnormalities. So these are the initial presentation for the infection. Whereas erythrocytic phase prodrome shows several signs and symptoms. That is, the early signs and symptoms of the erythrocytic phase are here, such as headache, anorexia, malaise, fatigue, myalgias, non-specific complaints such as abdominal pain, diarrhea, chest pain, and arthralgias. The paroxysm can be high fever, chills, and rigors. That is, paroxysm is nothing but the sudden attack or the outburst of signs and symptoms such as high fever, chills, and rigors can be seen in the erythrocytic phase. We can also see the cold phase is characterized by severe pallor, cyanosis of the lips and nail bud, and cutis anserina. So this is nothing but the goosebumps, that is goose flesh. Whereas the hot phase is characterized by the fever between 40.5 degrees Celsius to 41.41 degrees Celsius. Followed this, you can see sweating phase by 2 to 6 hours, and in the sweating phase you can see the fever results. Also you can see the marked fatigue, drowsiness, warm, dry skin, tachycardia, cough, severe headache, nausea, vomiting, abdominal pain, diarrhea, and delirium. In case of falciparum malaria, you can see lactic acidosis and hypoglycemia as well. There are also signs and symptoms such as anemia and splenomegaly. In case of the Plasmodium falciparum infection, you can see hypoglycemia, acute renal failure, pulmonary edema, severe anemia, thrombocytopenia, high output heart failure, cerebral congestion, seizures, and coma, and adult respiratory syndrome. The falciparum variety is the most serious form with high morbidity and considerable mortality, especially so in children and in travelers who visit the endemic area. So if these signs and symptoms are visible or observable, we should suspect the Plasmodium falciparum infection. Now, coming to the complications of malaria, especially falciparum malaria. Falciparum malaria is dreaded on account of the development of pernicious complications. So, the pernicious complications should be anticipated when more than 5% of erythrocytes are parasitized, or more than one parasite is seen in the same RBCs, and the growing forms of the parasite are seen within the erythrocytes in peripheral blood. Okay. Then The pernicious complications of anemia include cerebral malaria, malarial hyperpyrexia, gastrointestinal and hepatic forms, renal failure, algid malaria, and blackwater fever. So, these are the complications of falciparum malaria. The WHO has stated that the occurrence of any one of the following clinical presentations would qualify for the term severe falciparum malaria. So, if the patient shows any one of the following signs and symptoms, then we can suggest the patient may have severe falciparum malaria. So, those signs and symptoms are cerebral malaria, severe anemia with PCV of less than 15% or hemoglobin of 10,000 per microliter, and renal failure, urine output of less than 480 ml per 24 hours in adults, and in children 12 ml per kg for 24 hours, and serum creatinine of more than 3 mg per dl. And next one is the pulmonary edema or respiratory distress syndrome, and finally hypoglycemia, whole blood glucose. So when we are performing the blood glucose, when we are checking the glucose level, if the patient is having hypoglycemia, then pulmonary edema or respiratory distress syndrome, renal failure, severe anemia, cerebral anemia, then we can suspect that the patient have severe falciparum malaria. So among those, let us discuss cerebral malaria in detail. Of all pernicious forms, involvement of the central nervous system is the most important life-threatening event that should be recognized early. Vivax malaria causes central and peripheral neuronal alterations only very rarely, whereas Plasmodium falciparum neuronal involvement in is much more common. So, as to make the term cerebral malaria is almost synonymous with Plasmodium falciparum lesion. The two major pathological processes in cerebral malaria are sequestration of parasitized erythrocytes and metabolic changes including hypoglycemia and acidosis. In adults, the former mechanism predominates, that is, the first step, sequestration of parasitized erythrocytes, whereas in children, the picture is a combination. So, in children, you can see both the steps. There is increased expression of the vascular and intercellular adhesion molecules and rise in tumor necrosis factor, interleukin 1, soluble thrombomodulin, and lymphotoxin. The clinical spectrum is related to the extent, site, and the duration of the involvement. The involvement of the central nervous system is the most severe presentation of the falciparum malaria. So, this is invariably fatal if untreated. If recognized and treated early, the mortality may still be up to 10%. Delay in treatment worsens the prognosis for mortality and morbidity. The clinical presentation depends upon the site of the maximal affection. So here is the features, predominant features in the cerebral malaria. So you can see the sites where maximal lesions are observable and the clinical presentations respective to them. So in case of frontal lobe, you can see organic brain syndrome, cerebellum, cerebellar disturbances, pyramidal and or extrapyramidal system lesions. We can see human lesions or extrapyramidal lesions. In case of the cerebral blood vessels lesion, you can see strokes and brainstem lesions. So you can see brainstem syndromes. In case of spinal cord, paraplegia and monoplegias, spinal root and peripheral nerves can be resulted in Guillain-Barré syndrome. and peripheral neuropathy. And in case of the involvement of meninges and subarachnoid bleed, that can result in meningeal syndrome. So these are the predominant features in the cerebral malaria. So onset may be sudden or subacute with changes in hair function, signs of meningitis or seizures. Affected patients may all on a sudden throw seizures followed by persistent coma. So subarachnoid bleed, retinal and intracerebral bleed, vasculopathy or disseminated intravascular coagulation are the other forms of the presentation. And the presence of neck stiffness, raised intracranial tension, and cerebrospinal fluid alterations such as increase in protein and lymphocytosis are common in cerebral malaria. Presence of features such as urticaria and disseminated intravascular coagulation may suggest a clinical diagnosis of bacterial or other forms of meningoencephalitis. So, you can also see the development of the neurologic sequelae in up to 10% of the cases. These include hemiplegia, cranial nerve palsies, paraplegia, aphasia, extrapyramidal features, cerebral dysfunction, peripheral neuritis, amyotrophic lateral sclerosis like picture, and psychosis. Even though those complications accompany or follow the clinical picture of cerebral malaria in most cases, occasionally post malaria neurological complications may develop after full clinical recovery and parasite clearance. These include convulsions, cerebellar ataxia, tumor like syndromes, and psychosis. Retinal lesions include hemorrhage, pallor of optic disc, retinal vessel changes, papilledema, and cotton wool patches. Retinal lesions may be associated with higher mortality. With clinical recovery, the retinal lesions are also resolved and prognosis for vision is good. At times, retinal lesions occur without clinical cerebral malaria. So, let us see the malaria in children. Manifestations of Plasmodium falciparum malaria may differ in children. In non-immunes, Plasmodium falciparum malaria carries a higher mortality than in partially immunes. Children are the most frequent victims. So here are the clinical features that exist in children as well as in adults. So you can see cough is uncommon in children whereas it is common for adults. Convulsions and neurological sequelae are common and rare for both children and adults, and jaundice is rare in case of children whereas it is common in adults, while the pre-treatment hypoglycemia is common in children and uncommon in adults. You can also see the pulmonary edema and the renal failure are rare and more frequent respectively in children and adults. Now coming to the diagnostic testing, malaria should be suspected and excluded in all persons with fever who have traveled to an endemic area within the previous year. Diagnosis is made by visualization of parasites on Gienza stained thick blood smears. Smears should be obtained during febrile episodes to maximize the parasite yield. So we should collect the smears when the patient is having febrile episodes. Rapid diagnostic tests targeting antigens common to all Plasmodium species as well those specific to Plasmodium falciparum are available but should be confirmed with microscopy. So here is a perfectly stained blood smear slide of Plasmodium falciparum. So this arrow shows the parasites in the erythrocytes or RBC. So here you can see the parasites inside the ABC. So this is all for today. The remaining portion we will discuss in the next section. Thank you.